therapy in prostate colorectal cancer. I have to say that it's sponsored by Amgen.
Yes, and I want to thank Amgen for adding me on the list. So I will address two kind of rather new concepts that may be important to consider in the future, which is deepness of response and convalescent surgery, but also early tumor shrinkage. So the definition of early tumor shrinkage, which is the first thing that we could measure for a patient, is the time to tumor shrinkage from the start of the treatment. It is just measured at the target lesion, and the cutoff used in the trial that have addressed the question is either 20% decrease in the tumor size or 30%. I personally prefer 30% because it matches perfectly with the RECIST criteria, and it is generally done in most of the trial. We use FOLFIRI or FOLFOX at 8 weeks, meaning before the fourth cycle. The early tumor shrinkage will reflect the sensitivity of the tumor to the treatment, and it may predict deepness of response. Deepness of response is another item which is measured over all the course of the disease, and it measures the decrease in percentage from the initial size to the size at all evaluation, and it might be related to overall survival. In addition to that, it may also facilitate surgery, because surgery is always limited due to anatomical factors like vascular structure, and if the response is deeper, this surgery may be more feasible. So, and this is the theoretical concept. This is drawn out of a biomathematical model, so it has some weaknesses, but you have two situations here, one in black, where there is some response initially and then the tumor grow, and there is another regimen that will shrink the tumor earlier, like in blue, and deeper. And even though in this model they considered that the tumor growth was linear, which we know is not the case, this would explain why, if you have a deep response, finally you will get an overall survival benefit. So this has been looked at in a variety of trials. The first was the PRIME trial, which you know well, FOLFOX versus FOLFOX panitumumab, that was positive on PFS, OS, and response rate on the RAS wild-type population. And if we look at the outcome according to early tumor shrinkage at 8 weeks, you see that the cutoff here was 30%, and we see that the patient with more than 30% reduction in the tumor size, meaning an objective response at week 8, have a much longer PFS of almost 15 months versus 9.3 if they don't. And there was also a longer survival of 34.5 months versus 18.2 if they don't. If you look at the control arm, actually the conclusions are the same, meaning that this early tumor shrinkage, whatever the treatment you give, is a good indicator of a potential longer PFS and overall survival, and this is shown on the curves here. You see the two solid curves. In blue was more than 30% shrinkage with FOLFOX panitumumab, in red with FOLFOX alone, and the dotted curve below was the patient who did not make it for 30%, and clearly their outcome is not as good. And this is important also in patients with liver-limited disease, and we have looked at that in the PRIME trial. Of course, we have very few patients, as you can see, 89 total, because this study was for unresectable patients. However, you see the difference in response rate between FOLFOX in purple, 66%, and FOLFOX panitumumab, 79%. But if we look at early tumor shrinkage at week 8, you see that the 79% of patients who would be objective responders were already objective responders at week 8. The response rate does not increase after time. It's an early tumor response, whether the patient with FOLFOX alone only had a 51% early tumor shrinkage, and overall later they will respond further and have a 66. So this is clearly showing an early response. If we focus now on the impact of this early tumor shrinkage on resection rate, 9 out of 41 were resected in the FOLFOX, and 15 out of 48 were resected in the FOLFOX panitumumab, and more importantly, R0 resection, that may be associated with cure, shows that 7 out of 9 were R0 in FOLFOX and 14 out of 15 in FOLFOX panitumumab. So this is an important parameter to consider because it occurs early, and also you don't need to use too many cycles of FOLFOX panitumumab before surgery, and most of the liver surgeons prefer to operate on the liver before there is too much chemo-associated toxicity to the normal liver. If we look at the impact on disease-free survival of the resection in the liver-limited disease, you see that for the patient who were resected, whatever the type of resection of their metastasis, the 3-year DFS was 78% versus 41 for the one who could not be resected. And for the R0 resection, it was 84 versus 41. And the contribution of panitumumab in addition to FOLFOX is 55% versus 44% with FOLFOX alone. A similar analysis has been done in the 3 head-to-head comparison of bevacizumab with anti-EGFR that have been detailed by Dr. Schmoll before. If we look at the same item in the PIC study, we end up with the same conclusion. Again, the cutoff here was 30%, and you see that on the left part of the panel, the patient who did not make it at the first evaluation at 8 weeks have a similar PFS of 9.8, 9.7 months with both regimens. But the one who did it with more than 30% reduction have a longer PFS of 13 months with FOLFOX panitumumab versus 10 months with FOLFOX bevacizumab. Of course, this was not significant due to the low number of patients. We have done a similar analysis at 20% shrinkage because this was done in another study, and the conclusions are the same. Patients treated with FOLFOX panitumumab have a longer PFS as compared to FOLFOX bevacizumab if they have more than 20% tumor shrinkage. And if we put all that together in the PIC study, you see that the objective response, as said before, was not overall improved, but the median time to response was 2.3 months with FOLFOX panitumumab and 3.8 months with FOLFOX bevacizumab. So a longer time to respond, which is important to consider, especially if surgery is concerned. If we look at now the duration of response, DOR, it was 11.4 months in FOLFOX panitumumab versus 8.5 months in FOLFOX bevacizumab. So an earlier response and a longer duration of response, and the deepness of response was also improved in the panitumumab arm, 65% median decrease in size versus only 46 for bevacizumab. And again, this has an impact if you look at the lower panel on overall survival. The median overall survival for the patient in FOLFOX panitumumab was 41.3 months, associated with a 65% deepness of response, whether it was only 29 months with FOLFOX bevacizumab, associated with 46% deepness of response, and both were significant or almost significant, but this study needs to mature to have more overall survival events. Interestingly enough, this is also correlated to the level of CEA. You see the level of CEA in blue in the panitumumab FOLFOX and in black in the bevacizumab, and it really follows the early tumor shrinkage. It means that if you see a patient and you do a CEA at each cycle, you may have ahead of time an idea of how tumor shrinkage is going to be, both in terms of deepness and time to response. And if we take this same illustration, but according to peak, you see that in peak we had a difference in PFS that was not seen in the other trial. In red is the bevacizumab arm, in blue the panitumumab arm. So a better early tumor shrinkage with panitumumab, better deepness of response and a longer PEF, and at the end an improved overall survival, again, which is not significant from a statistical point of view, but from a clinical point of view, it is more than a year. So it is meaningful for a patient. Now these are the numbers. We can save time on that because they have been presented on a poster, and the survival curves according to the progression-free survival according to the tumor shrinkage, more than 30% on top, less than 40% on the bottom. This was done also in the FIRE3 study, and in the FIRE3 study, the early tumor shrinkage was 68% in the cetuximab arm, 49% in the bevacizumab arm. And this, again, correlates with a longer survival. For those patients with an early tumor shrinkage at week 8, again, the median was 9.7 months. The median overall survival, 38.3 months in the cetuximab. Those with no early tumor shrinkage at a shorter PFS at 5.8 months, and their median overall survival was only 20.5 months. Similarly, but to a smaller magnitude in the bevacizumab, the median PFS for the patient with an early tumor shrinkage was 11.7 months, and no early tumor shrinkage, 8.3 months. And for overall survival, same magnitude of benefit also, 31.9 months in overall survival for the one with an early tumor shrinkage, and 21% for the one with no tumor shrinkage. So the important point here, if we believe that there is an effect on early tumor shrinkage on PFS and OS, is to take the regimen that provide the highest early tumor shrinkage, in this case FOLFIRI cetuximab. This is the same design again. In the FIRE3, as said before, there is no difference on PFS, but again, considering that the tumor regrowth is at the same speed after progression, this would explain why, starting from a lower tumor burden, we at the end show or see a difference in overall survival, even though there is no difference on progression-free survival. This was recently also analyzed in the older CRYSTAL trial. CRYSTAL was FOLFIRI versus FOLFIRI cetuximab. And again, if you look at the left upper panel, patient with a more than 20% early tumor shrinkage in red, and patient with less than 20%, there was a big difference with the hazard ratio of 0.32 on PFS and 0.53 on overall survival for the FOLFIRI cetuximab. Same phenomenon was seen in the FOLFIRI without cetuximab, the control arm, but here the magnitude of the benefit is not as large as when cetuximab was combined with FOLFIRI. These are data that were shown already by Dr. Schmoll before. In the CALGB, there was an improved response rate as compared with cetuximab as compared to bevacizumab. The number of resected patients is low, and personally, I would not trust CALGB too much because these data have not been fully analyzed. For the whole RAS population, it was done only on 55% of the total population. Unfortunately, this year at ASCO, there will be nothing new from CALGB. I don't know what they are doing with the data. We still don't know the number of cycles received, the dose intensity, the reasons for interruption, and so on. So it's really difficult to make a decision now on the CALGB data, which needs more maturation or more information for us, at least. This question of early tumor shrinkage and deepness of response was also addressed in the TRIBE study, FOLFOXIRI bevacizumab versus FOLFOX bevacizumab. And here again, where we have already mentioned the response rate that was overall improved by FOLFOXIRI, 71% versus 62%. But if we look at the earlier response, we see that there is an advantage of chemointensification with a shrinkage of more than 20% in almost 63% of the patients versus 52% when FOLFIRI was used. And similarly, the depth of response was around 38% with FOLFIRI bevacizumab and 43% with FOLFOXIRI bevacizumab. So these are parameters that may be important to consider in a future clinical trial, especially for patients with liver or lung limited disease. And this on the right column is the outcome of early tumor shrinkage in TRIBE. You see the benefit on PFS, the benefit on PPS, which is post-progression. No, I don't remember what it means. It's measure right after progression, and the overall survival that was also improved. So, in summary, in the first line, EGFR and cetuximab prolong overall survival versus chemotherapy alone. This has been demonstrated mostly in Crystal, Opus, and Prime. Now, if we consider this additional endpoint that are ETS and deepness of response, there may be an advantage to the use of anti-EGFR in first line as compared to bevacizumab, at least in PEAK and in FIRE3. These data have not been reported in the CLGB so far, but they may be important to consider as additional endpoint of efficacy in that setting. Thank you for your attention.
Thank you so much for this elegant presentation, and I think we have 10 minutes for questions, and I start by myself. I'm just wondering whether RECIST criteria is still reliable or valid for assessment of patient receiving targeted treatment, not only in colorectal but in other areas like lung or even renal carcinoma. This is the first question.
Yeah.
The second question about the early tumor shrinkage in colorectal cancer in the FIRE3 trial. There was no difference in terms of the outcome in the patient who did not achieve early tumor shrinkage. So from the economic point of view, why should we carry on adding cetuximab if the patient did not achieve early tumor shrinkage?
I understand your point. I will answer your first question. RECIST is far from being perfect. The difficulty with RECIST measurement is more in patients treated with anti-angiogenic agents, where quite often the tumor becomes necrotic, but the size itself does not decrease. So some report use modified RECIST looking at density and other parameters or blood flow in dynamic ultrasonography. But the point is, especially for patients who may potentially be resected, is the anatomical aspect and how far from the big vessels the tumor are. So RECIST is far from being perfect. There is probably some imaging tools that can improve the analysis of the images by three-dimensional reconstruction, and this is not routine practice. Now, for your second question, it is true on retrospective study that the patient who do not get an early tumor shrinkage do not have a major improvement as compared to patients who do. And this raises, you're right, the point of shall we continue using the targeted therapy? And there are two reasons for that. This is first, the toxicity associated with it, and second, the cost. And this reminds me of an analysis we've done in the PRIME study with skin toxicity. Similarly, the patient with no skin toxicity or grade 1 skin toxicity after cycle 3 do not get any benefit from the targeted agent. And at this point, the question should be asked, should this be continued? From my point of view, the answer is no.
No.
There is an ongoing trial, which is called Everest-2, which is a chemo, I don't remember if it's FOLFIRI or FOLFOX, with cetuximab, and they evaluate the skin toxicity, and in patients with no skin toxicity above 1, they randomize escalating cetuximab until skin toxicity or stopping cetuximab to see whether by increasing the dose and getting skin toxicity we will get more efficacy or whether the drug should be stopped.
Thank you so much. Any other questions?
An increased resection rate. So my interest would be, how were these cases calculated in terms of the evaluation of overall survival? Because clearly, if you resect, then of course these patients per se have a better prognosis. So on the other hand, you could argue if you downsize the tumor so much that you can resect, it's good for the drug. But anyway, there's a certain bias induced by resection.
I fully agree on you on the bias. This is why I said this is a retrospective study. But overall, if you consider the entire population in which a very limited number of patients were resected, I don't think the extended progression-free survival or overall survival is only due to those patients who were resected. We have not done an analysis taking out the patients who were resected, but this is a good suggestion. But I fully agree with you. But anyway, on a single individual basis, if you can resect, it's always better.
Can I just say? Okay. Just a comment to Jean-Yves Duyar's nice, very good presentation. But all the data show that what we know since 30, 45, 50 years, that the biological phenomenon response to chemotherapy or any treatment is just reflecting the biology of the tumor, and it's nice to see you. And you can select the patients afterwards. If you give treatment and see good response, it's a better biology, a better patient, it's a better outcome of treatment, any treatment. So it's a universal phenomenon, not phenomenon, a universal characteristic of treatment in oncology. So it's not an invention of the EGFR inhibitors, it's just a use of this characterization or phenomenon or reuse in the modern trials. But my question is it really shown that the resection rate in colorectal liver metastases in cetuximab versus bevacizumab, the same population, is really increased, the resection rate increased by cetuximab due to the higher or deeper response? Is this really proven? I don't understand the data, or I don't know the data.
No, this is a retrospective analysis. Nothing is proven. I think we may partly have the answer to this question with the BOSS-2 trial, which is the next trial after New Epoch, which is taking patients with resectable disease and comparing perioperative chemo to perioperative chemo plus targeted agent according to the RAS phenotype. This will give us a little bit more information.
From the current head-to-head comparison trials, is there any indication that the resection rate in the liver only is increased from cetuximab versus the bevacizumab? depending on the higher deepness of response, what you claimed there?
I don't think so. This was not provided in the CLGB with all the limitation of that study. We looked at that in the PRIME study, but PRIME was not comparing anti-EGFR to bevacizumab, and FIRE 3 didn't do it, and PIC is much too small to do it. So this would be another question.
Oh, okay, thank you very much. I would like to thank all the speakers and the chairperson who are with me today. And now we are going to finish this session, and I think now it's time for lunch. Thank you.